Today I'll be doing a case discussion on colorectal carcinoma, and these two I'll do as two discussions. And at the beginning, coming out of the normal way of giving a clinical case and discussing, first initially I'll do an overview of the various presentation of colorectal carcinoma. And here I have listed it as a symptom web, which I'll tell you why I named it like that. But before I open up this discussion, uh, take a piece of paper and write down the various symptoms, initial presenting symptom which may be there in a colorectal carcinoma, that is a carcinoma from cecum up to the rectum. Take one by one and just try to work out a common pattern of the various symptoms which a colorectal carcinoma can present. Do that and compare with my discussion. So pause the video, do that and discuss to make this discussion more interactive, and you can check your background knowledge that what you have, and it will also allow you to remember it better if you do that way. So of course it could be, the symptoms could be due to the primary pathology, or it could be due to metastasis, because we know sometimes colorectal cancer, or like any other malignancy, the first presentation is due to metastasis, and then you work back, only you identify the primary pathology. So first, to look at what are the possible primary the symptoms of primary pathologies, it could be some form of bleeding. And as we have discussed this in a initial lecture, any malignancy in a hollow viscera due to the ulceration, bleeding is a common way a malignancy can present in a hollow viscera. And the bleeding can be in three forms. I'm sure you have listed this. It could be a bleeding PR, where the bleeding is bright red due to a malignancy in the left side of the colon. Or it could be coming as a melena due to a lesion more proximal, especially the right colonic lesions. And here we have to remember the differential diagnosis becomes broader, because melena can be due to bleeding from the upper GI as well, and also the lower GI. Actually, the definition starts from the ligament of Treves. So melena can be any part of the GI system. So the differential diagnosis becomes broader. Or they can present with occult blood loss, that is with features of anemia, where they come with usually with shortness of breath. And here the differential diagnosis is even more broader than the melena, because here all forms of anemia will be there in the initial differential diagnosis. And if it's a shortness of breath on exertion, the respiratory and cardiac causes also has to be excluded, and then anemia and various forms of anemia, and then so it's a very much broader differential diagnosis. And this melena and occult blood loss, the differential diagnosis discussions I have done in my previous lecture, which I uploaded on upper GI bleeding. So you can cross refer to that later on. So, but anyway, your colorectal carcinoma, your bleeding, they may present with some form of bleeding. And also they can present with some alteration of bowel habits, which could be a constipation. This happens mostly in the left side colonic lesions, the descending colon, especially the sigmoid, rectosigmoid regions. They come with constipation. But it's very important when a person says constipation to ask exactly what they mean, because they mean different things. It's very important to ask how many times how often they go to the toilet. Is it that they were going every day and now it's in one in like 4-5 days? Because for some people just hard stool also they say it's constipation. And if the constipation is ignored for a long time, of course, they can even present with a bowel obstruction. Constipation is not a predominant feature of right side colonic malignancy like CA cecum, but we have to remember a CA cecum also for the first time, they can present with bowel obstruction because they can obstruct the ileocecal valve and lead to a small bowel obstruction. In a left colon, it is a large bowel obstruction. So, even though they come with bowel obstruction, by analyzing the symptom pattern, you can identify whether it's a small bowel obstruction or a large bowel obstruction, and also your imaging will tell. Or your alteration of bowel habits may be an increased frequency of defecation, where the number of time they are going to the toilet has increased. And also the initial presentation may be something of local infiltration, where they have either ignored the other things. So the local infiltration you can work out for different parts of the bowel, studying the anatomy related to that part. But the symptoms of local infiltration are mostly seen in rectum because it's a compact space and infiltrate into, and there are a lot of other structures like your bladder, the vagina, and also the ureter. So many things in a close compartment that local infiltration you see mostly in the sigmoid, but other places are also not immune now. Even like transverse colon, it may infiltrate the stomach or the pancreas, or the gallbladder may get adherent to that part and it can cause service. So anyway, it's, if you know the anatomy, you can find where it will infiltrate and the symptoms depending on the organ which is getting infiltrated. Like if it's in the rectum, it will be like bladder symptoms or vaginal discharge of feces, something like that. And the primary other thing is, for the first time they may notice a mass and they may come with a mass. It's common in the right ileal fossa, the cecal tumor coming with a right ileal fossa mass, because the person may have not noticed the melena or there was no melena. It simply was occult blood loss and they may have features of anemia, but the one that they have noticed is the mass. Sometimes it's the sigmoid tumor, so this may can happen. Why I am talking as a symptom web is that the initial presentation may be one of these, maybe bleeding PR, maybe melena, maybe shortness of breath of anemia, or they may come with a constipation. But at the same time, one of or more of these also may be present, like a person coming with bleeding PR, when you inquire, they may recall, okay, now I am getting constipated, or they may say, oh yes, I am now going more times to the toilet. Or a person coming with local infiltration, like say like a fistulation to the bladder, like a pneumaturia or fecal urea. When you ask, okay, they may say, yeah, for the last months I had bleeding PR and also I was getting constipated, something like that. So their presenting symptom may be one where which most bothering they come and tell you, but they may have, sometimes they may not have, but they may have either one or other of these. So it's important to inquire also you develop this entire picture for the patient. And then, and also a person coming with primary symptoms may have already have metastasis, symptoms of metastasis, like a person coming with bleeding PR and alteration of bowel habits, you diagnose as a CA rectum, and there may be already liver met. So when you ask, okay, he may say, yes, I have some fullness in the upper abdomen, more towards the right side. Sometimes the initial presentation is entirely due to a metastatic disease. Not common, but it may happen, and you have to be alert about that. Like a person who comes with a right hypochondrial fullness, and you take a history examine, and you find a liver enlargement, and therefore it's very important to look for causes of liver enlargement, and primary tumors are one, and you have to ask symptoms about any GI pathology also, and of course your scan will show your myths, and then you work out and you find its deposits, and screening you do upper GI and a colonoscopy, and that may be the way that you find the primary. So it's very important to be alert about all these things. And another exercise I like you to do is take each symptom one by one. Like take bleeding PR, and then list the differential diagnosis, and then develop a history for yourself. Taking each cause for bleeding PR, you ask various symptoms either to confirm or exclude, and then you take, say, you diagnose one condition, and in the systemic inquiry, what if this whether this disease can affect the other systems, and then what symptoms I'm going to ask for, like a hemorrhoid. Uh, Cystic inquiry maybe that they have lost blood and they have symptoms of anemia, like a shortness of breath on exertion, or like a C rectum, whether they have spread to liver or they have infiltrated urethra and you have various symptoms due to that, or the bleeding PR, your differential diagnosis, you have diagnosed ulcerative colitis. Again, it can affect the other systems because you have extraintestinal manifestations in ulcerative colitis, like various eye symptoms or liver problems, or so many skin manifestations. So it's very important to have a total control of the situation, identify the pathology well, the systemic focus, and then you can take a very good history. And also you can then next take Melina, list the differential diagnosis, and think what is the history that you are going to take. And then compare with the discussion that I have done under upper GI building. So for each one, you can practice for yourself and then compare with whatever guidelines you have, maybe some things in this lecture or my previous lectures, or you may have other books to refer, so many things. So I'll just take one for discussion. A male is 40 years who has come with bleeding PR for 2 months, and I expect you first to do your differential diagnosis, history, examination, investigation, and then open up my discussion and then compare. So in a bleeding PR, initially, of course, now it has been given as 2 months, and is important, of course, then you first list your differential diagnosis. Then you can ask questions related to one. Then one thing is that bleeding PR, you can also qualify, like whether it's actually the color, is it really bright red, or sometimes there's blackish thing, they may say bleeding PR. So it's important to see it's a fresh blood, and the amount may be important, how much. And then the timing of the bleeding is a important thing, because these various pathologies, your the timings may be different. Now this is the differential diagnosis, I'm sure you have listed this amount or maybe more than this. And now say like hemorrhoids or a fissure, your bleeding is at the edge of your the bowel, so the bleeding actually happens at the end of defecation. At the end of defecation they may have some bleeding, or like a carcinoma rectum or sigmoid, the stools may be just streaked with blood, or sigmoid, or in the descending colon the stools may be mixed with blood, and you see this mixing with blood even this time, because ulcerative colitis may extend to a higher levels and you have mixing of blood. So that is one important thing. So this is what I was highlighting. And say if it's the end of defecation, if it's just little bit of blood with lot of pain, it is like to be a fissure, and it's a skirting of blood, and he may notice also lumps coming out, it may be hemorrhoids. But the only thing is very important, like a fissure, of course, it's very straightforward because bleeding is not major, it's a severe pain and you can see the fissure. But in hemorrhoids, you have to be careful. I mean, everything may suggest hemorrhoids, but if you have a suspicion, always it's better to do a sigmoid. So practical lesions, a significant bleeding PR, people now say a sigmoidoscopy is mandatory, but workloads, of course, clinicians may have slight deviations of practice, but learn the correct thing from your beginning of life. Now in this also, so this is what I said about the stools getting mixed with blood. I typed all these just because a lot of students requested some form of text in the slides, so it's for easy reference. And so these things you can ask. And one important thing, after taking the various inquiry about the type of bleeding, by which itself you may have now a clue, just asking some few questions about the bleeding PR, understanding the pathologies, you now already you may have a clue. Okay, maybe hemorrhoids, maybe a fissure, maybe malignancy. And then what is the next question that you are going to ask? What is the most important next question? I'm sure you will tell this next inquiry is the bowel habits. Because if there is an alteration of bowel habits, always there has to be some sinister pathology. It cannot be a fissure or a hemorrhoid. Even the fissure, they may say the stools are hard, but they go to the toilet. It's a pain which is bothering them. So that's what you have to remember. And if the person has a constipation, like to be a left side colonic lesion, like a very like to be a carcinoma, but sometimes maybe even a diverticular stricture. And if it's the frequency is increased, it may be a carcinoma rectum and something like ulcerative colitis. So the next important question that you are going to ask is about the alteration of bowel habits. Now supposing, now this person this actual person who came to our clinic a couple of weeks ago, so he had a fresh bleeding PR and it was mixed with stool. And then when we asked about the bowel habits, he said that he has increased frequency of defecation. So when a person has increased frequency of defecation, what is the next question that you are going to ask? Think for it and start looking at the presentation. It is the volume that you have to ask, because if the person has a very large volume and is the short history, large volumes, it may be just some form of gastroenteritis or some form of dysentery. But if the stool amount is very little, now this person, our patient, we are presenting who had bleeding PR, mixed stool, bright red blood, he said his frequency is increased to about 10 times. And some days he said it's even more. But he said, I'm passing only very little stool, hardly stool, little bit of stool with blood and a lot of mucus. If he says this history, I'm sure you will agree your next question is going to be, have you got any incomplete sense of evacuation? People name it as tenesmus, but you have to ask the person in practical language. And if these all symptoms are there, with those 4 questions or 4 answers, you are diagnosing a CA rectum. Bleeding per rectum, increased frequency of going to the toilet, and then there's mucus and blood with each stool with little amount of stool, and there is incomplete sense of evacuation. 4 things, focus history, you are diagnosing a CA rectum. But there are 2 other pathologies which may mimic this history. You just find out when you read, you come across, you find out. And now supposing another person comes with this type of history, bleeding per rectum, and the frequency has increased, but he has some amount of stool and there is no incomplete sense of evacuation, but just he keeps on going to the toilet and he passes some stool, and the history may be a little longer and it is fairly suggestive of ulcerative colitis. So these few things here and there allows you to make a diagnosis well. But as I said earlier, if with the bleeding PR, if he's bright red blood, if he's getting constipated, then of course you put all your bets more for a CA descending colon or the sigmoid. Diverticulosis is also a possibility. So now this patient again coming back, we have diagnosed as a C rectum because he has bleeding per rectum, increased frequency of stool, little quantity each time, there are a lot of mucus, blood, and sense of incomplete evacuation. So after that, now we have to think of what is the further GI, and then what is the systemic inquiry, and the question should be based how this disease can affect the GI system itself and also the other systems, and also do an independent inquiry even if the pathology is not going to affect the other system. So obviously here it is a malignancy, and it can affect other systems by spread locally and to distant sites. So you have to ask any symptoms of local spread like hematuria, more than hematuria, pneumaturia, and fecaluria, and also female with there's a vaginal feculent discharge, and also urinary infiltration, bilateral loin pain, spread to the liver, right hypochondrial persistent pain, and if it starts getting obstructed, they may get lower abdominal colicky pains, which may be relieved by going to the toilet, and also later on they can have things like loss of appetite and weight, which are very late symptoms if the disease is going to spread. And even rectum, so other systems, now we have done GI and urinary inquiry, we have asked thinking of the spread, and then respiratory and cardiovascular important because of the bleeding they can have shortness of breath on exertion, and independently you have to ask other things because you are treating a person like cough or any chest pain on exertion in other cardiac symptoms, and very rarely C rectum can spread to the lungs, so it also can give rise to uh, pulmonary symptoms, and it's not very common, but of course you cannot ever rule that it can spread to the brain, but like headaches you can ask, and also definitely more importantly severe backache because it can infiltrate the sacral plexus of nerves. So so this completes a fair amount of a systemic inquiry, and then all other things like your past medical history, past surgical history, uh, then your social history, occupations, family history of malignancy, because if there's a strong family history, you may have to screen the other family members. And the medical history is mostly important because in your further management, what medications is on, like there may be something like aspirin or warfarin, which you may have to stop or bridge during your surgery, and also past surgical if there were previous laparotomy, re-operation may have problems. So there are various reasons why you ask this, the other parts of the history. So so again I have typed all this for your future reference. Maybe few things I have forgotten to type, I spoke, you can make a small note. And then examination again, and like diagnostic investigations to spread, assessment of fitness. You write on your paper what are the things that you will do, and then compare. An examination, obviously you take a BMI, see with this pale jaundice, supraclavicular lymph nodes, not very common to spread from a colonic cancer, but it can happen in rare cases. So you have to feel the nodes, do a complete cardiovascular and respiratory examination, abdomen distension of ascites or early obstruction, and palpation any masses that you may palpable, and then liver enlargements, ascites, and do a rectal examination. If there's a growth, you have to characterize all the features. So now this patient we are discussing again, the person who came with bleeding PR had a lot of history just of a C rectum, but his systemic inquiry was fairly alright. There was no evidence of further spread, and examination. The positive thing was that on rectal examination there was a palpable growth. So what is the diagnostic investigation you are going to do in his case? So I am sure you'll agree that it is it will be a colonoscopy, and I'll take you one by one. Now, even if the carcinoma you are suspecting with your history, like say even it's cecum, still it is colonoscopy. So whatever area of the colorectum you suspect a malignancy, your diagnostic investigation is a colonoscopy, because you want to assess the lesion, and then you have to look at synchronous lesions. Maybe other malignancy is not very common to find, but is important. Another CA may be there, or maybe there may be other polyps. So your management strategy will be different. Your surgical management is going to be different. What part you are going to resect. So whatever the lesion. So when you are answering, give a full answer. I'll do even if a CA rectum, you say I'll do a colonoscopy because I want to diagnose, confirm, and also I have to look at other synchronous lesions. Uh, because sometimes the examiner may ask why not a sigmoidoscopy. You can say with sigmoidoscopy I can diagnose, but it's better to do a colonoscopy. And then also you should know how to prepare for colonoscopy. What advice you have to give about the ring in the clean prepare many things. This I have given in the hand outside that given for you all to read. So please read that. So I'll just show this the colonoscopy just for your interest. This of course shows a high lesion, not a rectal cancer, but just for a change that you can see the video, and this is how malignancy will look. And then of course you have to take multiple biopsies. Just one is not adequate because you may not take it from proper area, so better to take at least about four pieces. Good 4 pieces would be good, and look at. And this our patient, it was a rectum and it came as an adenocarcinoma. And then your next question is investigations to assess the spread, and I'm sure you have written it as a CT, abdomen and pelvis. Now the standard is also to do the chest at the same time. Some centers still they do the abdomen and pelvis only. Now for a rectum you can do endoscopic ultrasound, but these are more important for early lesions. If you are going to like do a perianal excision to know the exact spread, but MRI also it's good to assess the spread and all that, but MRI is also not used as a first line investigation. I mean, you can just, these two are good enough, but MRI, especially in rectal cancer, the sphincters and all, you can see better, so you can keep in mind. But in your what you do, when you answer the exam, you say I do a CT, abdominal, pelvis and chest, because that's a standard practice. But if somebody asks what are the investigations, you can get on to this. But if you are doing a essay writing, again you mention this, but you can just put a note. These things also are helpful, but you are not going to waste a lot of time discussing things which are not done often. And then you assess the fitness of the patient, because whatever things, most of the time it will be a surgery. And so if it's a CA rectum, now this person confirmed CA rectum and he didn't have any other spread, so your surgery will be either anterior section or APR. Now this the treatment, the management, I'll do in my second part of the discussion. So you can go through this first discussion first, because the more important thing for you is to take a history and make the diagnosis. The treatment you should know, but that part is important. So rehearse that, and then we'll get on to the second part of the lecture. But I just, what I said earlier, do that. That for each symptom, you take the differential diagnosis, and then what history you are going to take, and then you will know how to diagnose from cecum to rectum by various methods. And also, as a good practice, you can take the bowel, various parts, take cecum, and then think the other way, how a cecal cancer can present, like maybe right angle fossa mass, or maybe so right angle fossa mass. Okay, then what is the differential diagnosis of right angle fossa mass, and then what is the history around right angle fossa mass, and then CA cecum can present with occult blood loss. Then what is the differential diagnosis? What is the history? CA cecum can present with acute obstruction of the small bowel. So small bowel acute obstruction. What is the differential diagnosis? and what is the history, how I am going to diagnose. Then, so like that. So take each part, like the hepatic flexure, the primary symptoms or infiltrative symptoms. So you can just do as earlier. So in both ways, take a symptom and differential diagnosis, and then the other way, take one part, malignancy, what are the ways they can present, the differential diagnosis for each. So you will develop this web very well. So you work on both hands. So do this practice, and then you will be a master to make a diagnosis in colorectal carcinoma. You will never miss whatever the subtle way they are presenting. You will never miss the diagnosis.